All right, this lecture is going to focus on EKG changes that occur with electrolyte abnormalities. Many things go awry in the body when your electrolytes are out of whack, and the heart is one of the most important to remember. Three electrolytes that affect the heart in particular are calcium, potassium, and magnesium. So we are going to review the abnormalities that occur in an EKG when you have too high or low of each of those electrolytes. Let's get started with calcium. All right, hypercalcemia. What happens when you have too much calcium in your blood? This will cause shortened QT intervals, lengthened QRS duration, and a very severe bradycardia. So too much calcium, shortened QT interval, lengthened QRS duration. And on the flip side, if you don't have enough calcium, hypocalcemia, instead of a decreased QT, you will see a lengthened QT interval. And instead of an increased QRS, you will have a shortened QRS duration. So exactly the opposite of the changes we saw with too much calcium. Too little calcium, lengthened QRS, and a shortened QRS duration. So let's see what this looks like on an EKG tracing. Here, obviously not a real EKG tracing, but this will give you the best picture. We have our normal complex in the middle. You can see our P wave, our QRS complex, and our T wave. Very simple. Now to the left, we have too much calcium, hypercalcemia. So we're seeing a decreased QT interval. It's much shorter there, that QT interval between the big spike and where that T wave comes. And then on the flip side, for hypocalcemia, we're seeing that QT interval is much wider. There's a lot more space after the QRS complex and before the T wave starts. So hypercalcemia decreases the QT interval, and hypocalcemia increases the QT interval. The other change we mentioned was with the QRS complex. So big QRS complex in the middle. It's kind of hard to see on this picture, but in an actual EKG tracing with hypercalcemia, the QRS complex would be lengthened, and with hypocalcemia, it would be shortened. Just a little more narrow with hypocalcemia and a little bit wider with hypercalcemia. But you can see in this photo really well the change in the QT interval, how it's much shorter with hypercalcemia and much longer with hypocalcemia. So let's move on to our next electrolyte, potassium. There are a few very distinctive EKG changes that occur with hyperkalemia, too much potassium. One of the major side effects of too much potassium is the EKG changes. You will see tall peaked T waves, a prolonged PR interval, and a widening QRS complex. The tall peaked T waves are known to be an NCLEX question because they are so distinguishable. Let's go ahead and take a look at all of these changes with hyperkalemia on an EKG tracing. So at the top, you see our normal PQRST with normal potassium levels. This person might have a potassium of 4, 4.5, nothing too high yet. So going down, maybe we start to have a potassium of 5, 5.5. Immediately you see the tall peaked T wave. You see how distinguishable that is? It jumps right up there and you know, oh, my patient's potassium is getting high. If you note this on the telemonitor, you should immediately check a potassium, notify your healthcare provider, and see what interventions need to take place. You got to catch this stuff early. As we go down and look at the next EKG tracing, maybe this patient's potassium is more like 6, 6.5. You still see this tall peaked T wave, but you're also seeing a longer PR interval. Yeah, you see that first red arrow between the P and the R is really lengthening, and that P wave is kind of flattening out a little bit. This patient's potassium is at a dangerous level. We should have already caught it with the tall peaked T wave, but now we see a long PR interval, and we know this patient's potassium is really getting up there. Moving on to the very, very last picture is when our potassium is at near fatal levels, going on 7 or 8. We still see the tall peaked T wave. Our PR interval is so long, it's not even really there anymore. The P wave has almost disappeared, and our QRS is much widened. You see that first red arrow where it's really widened out, much wider than the previous QRX complexes that you see above. So at this point, we have really dropped the ball. We should never let anybody's potassium get to that point if they're inpatient being monitored. Now, that doesn't mean somebody won't come in as a trauma or very, very ill and you see this rhythm on the monitor. But we know at this point we need to address their potassium level very quickly because it could become fatal. Here is another EKG photo just so that you can kind of see each aspect really pointed out well. You see the widening flattened P wave there first, then the prolonged PR interval, the widened QRS, and the tall peaked T wave. Those are all of the hallmark signs that you want to watch out for. Given the widened QRS and the tall peaked T wave, you also have kind of a depressed ST segment that you can see there. We didn't mention that before, but with this diagram pointing out that part, you can see that as the QRS widens, that S drops lower, the T wave is very peaked, so that ST segment is depressed. I believe those are all the major changes you would need to know for the NCLEX on hyperkalemia and EKG changes. Tall peaked T wave is definitely going to be like your buzzword for hyperkalemia. But let's look on the flip side at hypokalemia. All right, so several noteworthy changes here with hypokalemia. Remember, this is a potassium less than 3.5. You are going to have a widening T wave with a lower amplitude, ST segment depression, increased P wave amplitude, increased P wave duration, increased PR interval, and U waves. That's a new one for us. A lot of these changes are the reverse of what we saw in hyperkalemia. So instead of the tall peaked T waves, you have widened T waves with a lower amplitude. You have the ST segment depression. You have increased P wave amplitude and duration, whereas with the hyperkalemia, we saw a flattening P wave until eventually the P wave just disappeared. You have the increased PR interval, and the U waves is something new for us. Let's take a look at what all of this looks like on an EKG. Here we go. So you have the slightly prolonged PR interval here, and that comes after, it says slightly peaked T wave. That is the opposite of what we saw with hyperkalemia. Remember, that was flattening out in the P wave. With hypokalemia, we're seeing a slightly peaked T wave, and then that PR interval is a little bit prolonged. You have the ST segment depression after that QRS complex, that coming down part before the T wave, it gets kind of low. And then the T wave itself is very, very shallow. With hyperkalemia, you had the tall and peaked T wave, but with hypokalemia, you have a very shallow T wave. And then here's that U wave, that last marker of hypokalemia. And just like tall peaked T wave was a buzzword for hyperkalemia, U wave or prominent U wave is going to be a buzzword for hypokalemia. If the NCLEX throws you a question that says your patient is presenting with prominent U waves, which electrolyte abnormality could they have? Your answer will be hypokalemia. That is the only electrolyte abnormality that presents with U waves. All it is a wave following the T wave that's generally a nice U-shaped. It's normally not tall, peaked, super duper long, but it is a wave that occurs after the T wave and, importantly, before the next P wave. It can be very easy to mistake a large P wave for a U wave if you're not counting your QRS complexes, but a U wave is a separate entity. So to really see somebody with that abnormality, you should be having P waves, QRS complexes, T waves, and then a prominent U wave, and then this whole thing starts back over. And this really only happens with hypokalemia, as we said. So There's a good full picture of the electrolyte changes with hypokalemia. We see the slightly peaked P wave, the prolonged PR interval, the shallow T wave, the ST depression, and of course the prominent U wave. Remember that one. All right, we will move on to our last electrolyte abnormality here, magnesium. So with hypermagnesemia, or too much magnesium in the blood, we will start to see flattened P waves, prolonged PR intervals, and a widening QRS complex, as well as a tall T wave. Now remember I said a tall peaked T wave is characteristically for hyperkalemia, too much potassium. You do still see a tall T wave with hypermagnesemia. You'll start to learn that magnesium and potassium often kind of go together. But tall peaked T wave will still be a buzzword for hyperkalemia on the NCLEX. Just know that you can also see it with magnesium. So one more time, we have flattened P waves, prolonged PR intervals, widened QRS complexes, and a tall T wave. Let's take a look at what that looks on an EKG quickly. So there we go. First thing you notice is the flattening P wave with a prolonged PR interval. That space between where the P wave ends and the QRS complex starts is much, much, much longer than it should be in a normal EKG complex. You also see a widening QRS complex instead of a really tall, narrow, sharp QRS. It's wide and kind of sloping, and then we see our tall T wave at the very end like we talked about. So this is the hypermagnesemia picture, too much magnesium. Now let's flip to the hypomagnesemia side to finish out our electrolyte abnormalities and EKG changes lecture. All right, hypomagnesemia, not enough magnesium. We start to see a lengthened QT, a broad and flattened T wave instead of that tall T wave that we saw with hypermagnesemia. And then there's a very important odd rhythm change that we can see with hypomagnesemia, and that is torsade de pointes. If there is an NCLEX question about magnesium abnormalities and EKG changes, it is most likely to be torsade de pointes. So let's kind of look at an EKG of the lengthened QT and the flattened T wave, and then we'll examine exactly what torsade de pointes is. All right, so here we have our EKG strip showing hypomagnesemia. First and foremost, you see the prolonged QT interval. So from the time that QRS complex starts to the time our T wave starts is much longer than it would be on a normal EKG. And then, of course, the flattening T wave. You can see here, although the photo is a bit fuzzy, that you really can hardly see any increase in amplitude for that T wave whatsoever. Whereas with hypermagnesemia, we had a really nice peaked T wave. It was quite prominent. So, in general, hyper is going to peak up your waves, give you more of an amplitude, and hypo, they're going to be softened, dampened, flattened. So again, this is hypomagnesemia, not enough magnesium. Those are the two basic EKG changes that you will see. The most severe and buzzword for the NCLEX that you could see is torsade de pointes. So let's pull up that EKG and talk about that rhythm change. So here it is, torsade de pointes. This is a supraventricular arrhythmia. Very uncommon. It means twisting on a point. So you see the increasing amplitudes, up, 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 and then decreasing, such as it's twisting on a point, going up and down. Hypomagnesemia is only one of the potential causes of torsade de pointe, or twisting on the point. There are some drugs that can induce QT prolongation and cause torsades as well. There can also be some changes with low potassium. If a patient has really, really bad diarrhea and is losing all of their serum magnesium, potassium that way, you could see torsade de pointe, although that would be quite extreme. And then there is something called congenital long QT syndrome, and those patients can also go into torsades. One common case that I have seen NCLEX questions about before are chronic alcoholics. They commonly have deficiencies in magnesium, and then that hypomagnesemia can cause torsade de pointes. This is considered a fatal rhythm if not broken, although some people can tolerate it for some period of time. It is a very serious complication that needs to be addressed quite quickly. So torsades de pointes, hypomagnesemia. Correlate those words for your NCLEX success, just like we talked about tall peaked T wave with hyperkalemia. Those are two really big ones to remember, but please go through this lecture a couple times, write down the major EKG changes, and you will be in good shape for those NCLEX questions. Thanks for listening.